A great time of year that we look forward to. I want to welcome everyone to our Dr. Harold Alper Humanitarian Award Lecture and Award Presentation. Our program this morning is going to be followed by a brunch in the POB in which you're all invited. We're going to have a photo session there of our nominees and our ultimate winner. But first, I want to introduce, and I'm very honored to introduce our Dean, Dr. Bruce Shack, to add to our welcome.
Thank you, Dr. Ford. This is indeed one of the highlights of our academic year here at the University of Tennessee College of Medicine in Chattanooga. This is an event that has been established by the Alper family, to their good graces and to their humanitarian support. We had a beautiful dinner last night at the Chattanoogan with all the nominees and at as their guests, and thank you for all the Alper support. Let me extend my congratulations to all the nominees. Being nominated is a winner. I mean, one of 9 out of a campus of 190. That's pretty good. So congratulations to all the nominees and to the ultimate winner, whoever that may be. And to everyone else here today, let me extend the welcome of the Dean's office, and thank you for coming.
Dr. Alper would admire our keynote speaker this morning, and he would be very interested in what she had to say, and he would welcome her with open arms. He would say that this is a physician role model. This is a physician who walks the walk. Here's a doctor who loves her patients and her colleagues and her students, and she learns from all of them. She helps guide them in their professional formation and looks forward to helping them in any way that she can. And that was the kind of doctor that Dr. Alper was every day. And that's why we're together to remember him and honor a group of exceptional graduating resident physicians who share the same values as Dr. Alper and our speaker. Now, we're not going to have time for you to ask questions after the presentation, but I encourage you to come to the POB to meet our speaker, and then you can have a conversation then. Our speaker is currently medical director of the Texas A&M Rural and Community Health Institute, and she's head of the Department of Primary Care Medicine. She's president emeritus of the Texas A&M Health Science Center, and notably the first ever woman president of the American Medical Association, having been awarded 6, I can't imagine that, 6 honorary doctorates. Dr. Nancy Dickey is one of America's most accomplished physician leaders, and I encourage you to read her impressive and extensive biography included in your written program. Dr. Dickey's a friend who I met about 35 years ago when I was Associate Executive Director of the Florida Medical Association. She was rapidly rising in the ranks of the AMA, and we knew that she was destined to one day become the first woman president. Now, little did I know those many years ago that my wife would develop breast cancer, and we would write a book together. But we did. And when you're an unknown author, it's important to include a well-known figure to write the foreword. I nervously approached Dr. Dickey with a manuscript, and I asked her if she would read it, and if she liked it, would she write the foreword. I knew full well that the president-elect of the American Medical Association was way too busy to do that, and way too busy to say yes. But she did. She read it and she wrote the foreword. And in the foreword she observed the following: how very often Rory, my wife, was uplifted by a smile an encouraging word, or a pat on the shoulder by someone on her care team, and how long she remembered the rare instance of thoughtlessness or careless comment. While physicians, nurses, therapists, and others spend long years learning the science of our professions, we must never forget that the humanity we bring to the science is as powerful a tool as chemotherapy or scalpel. One of the great benefits about working in the field of medicine is the extraordinary people you meet who you would have never met otherwise. You tend to develop a list of heroes. And Dr. Dickey is one of mine.
With that introduction, I think I'm just going to say thank you and sit down. Thank you, Dr. Four. You know, if he'd told me 35 years ago that they knew I was destined to be the president of the AMA, he probably could have saved me a great deal of angst and hard work. I could have just slid in there and skipped 25 years of politics. But thank you for those kind words, and for the pleasure of knowing you and Rory at least a little bit over the years. Thank you, Dr. Shack and members of the Alper family. What a pleasure to be able to spend some time last night getting to know them and hearing stories about the person for whom this endowment is named and who it honors. I'm pleased to be here at University of Tennessee, Chattanooga, because it's clear, not only from this program, but from all of the conversations last night, that you embrace and celebrate humanism in medicine. And to be with a school that teaches and models the characteristics that are part of relational medicine. You do so, obviously, in the midst of, very high-tech modern care, but you haven't forgotten that it's people that we practice on. I had a chance to meet several of the members of the nominees and to hear some of their stories last night as well. And I can say that if they're representative of the training and the graduates of this school, then you're turning out into the U.S. People who are going to be great caring doctors and role models, not only for the practices they join, but for the young physicians that they're likely to touch as they go through life. Well, we're going to talk about humanism in medicine. And so I thought maybe we should start by saying, what is that? It's an ethos. It's a culture. It's an approach to patient care that kind of defines what we do. Whether you're a surgeon or a family physician, a neonatologist or a radiologist, it's how you approach the people part of the science that you spend so many years learning. And it defines in so many ways how you use that science. It's communication, not just exchanging words, but really listening, taking the time to hear what it is patients are saying when sometimes their words aren't quite as clear in terms of that definition. It's compassion for what a patient's going through, or what a colleague is going through, because humanism is not limited to doctor-patient, but it's also people that have humanistic characteristics tend to use those characteristics in their relationships with the rest of the team and with their colleagues in medicine. It's recognition that patients bring their own cultures, their own values to the interaction, and that defines part of how they hear and accept what you have to offer them. But it's also recognizing that you bring your own values and culture, and that your values and culture oftentimes dictate how you enter the interaction. If we don't spend any time reflecting, thinking about who we are, then we may not, in fact, recognize how much of that culture of our own is influencing the interaction. And so humanism is big and sometimes messy and oftentimes difficult to define, but it in fact is at the heart of medicine. It was part of medicine long before we had all the spectacular technology that we use today. In fact, it was probably the most powerful tool that we brought to the bedside before science began making huge leaps forward. The patient's trust and belief that you were there to do something on their behalf and that your presence there brought some sense of hope was often the only tool that came out of that iconic black bag. And yet it was very powerful. It's important that we not put that tool aside, even as we move into more high-tech medicine. But culture's changing. Society's changing. And in the words of a 96-year-old cardiologist, maybe somebody that your father would have known, right? Dr. Bernard Lown, he said, "Doctors no longer minister to a distinctive person, but concern themselves with fragmented, malfunctioning body parts." He went on to say that hospitals are like factories. We test for every ache and we treat every lab abnormality, but we do little to heal the patients. Healing's replaced with teaching, caring is supplanted by managing, and the art of listening is taken over by technological procedures. He'd obviously become a little bit frustrated by where he saw his profession going, but in so many ways you can see some of those things happening around you in the hospital. The fact that high tech seems at times to be replacing our caring profession. But a lot of change has taken place, and how we relate to one another is very different today than it was even 20 years ago, let alone 40 or 50 years ago. Think about it. Snapchat. It's a camera that 180 million people use every day to take pictures and send messages back and forth. It's a multimedia messaging app that is segmented, I understand, into 10-second segments. So even if you take a long piece, they're going to chop it up for you into very brief pieces. Or maybe you prefer to tweet. Tweeting used to be, I think, 160 characters. It's become downright garrulous now. You can use 280 characters. That's a handful of words. And through that, we're going to do everything from national policy, it's amazing, to being the primary way of communicating with our family and our friends and others. Or, you could just skip words altogether. And you could use Instagram, which is videos and pictures telling a story. And while I don't tweet and I don't Instagram, and I had to look up Snapchat, I do have to admit I occasionally text when I don't really want to talk to the person that I'm sending a message to or answering an invitation from, because it's so impersonal to say, sorry, can't do that, or would rather do something different than what you're asking. We Americans cannot make a 10-minute commute across town without texting, calling, or tweeting, and the rest of our culture is equally demand-driven and urgency-fueled. We are just constantly in motion, it seems. I mean, think about it. Next day delivery from Amazon. I ordered it last night. Why isn't it here yet this morning? I haven't got time to stop for groceries. That's okay. I'll just type in my order, pull up to the curb, and they'll bring them out. I haven't tried that yet, but I understand it's really effective. Besides which, you don't do any of that extra shopping of one of these and one of those. But it does tell you a little bit about our lifestyles, okay? It's a job I have to do, but I don't really want to put any time aside for it. Urgent care centers on virtually every corner, because somehow we've communicated to patients, or they've decided, that if they have a symptom for a couple of hours, they'd better get to a doctor someplace, get it diagnosed, and have an intervention. Years ago, you would have waited to see what happened for several days and maybe made an appointment to see the doctor. Nope, got to get that done right now. Not just urgent and hurry up, but also kind of me-centered. My way, my time, get it all done. So, Dr. Lown, even as we chase immediacy, we also say that we're doing some of this because we're seeking work-life balance. And I had a chance to talk to Dr. Alper for a little bit this morning, and we talked a bit about what his father would have considered work-life balance. Actually, what I considered work-life balance was making sure that even though you were a very busy practitioner, that you made sure there was time in your life for your family, maybe even for a few hobbies, because after all, medicine and family is not enough. AMA was my hobby for about 30 years. You might golf or garden or do bonsai plants, something that would take your mind away from the stressors of what you did. But we considered our lives pretty balanced. Not everybody thinks that. I used to have a lot of students who would come out and spend some time in my practice, and I asked one of them, how come I had so many women students? She said, well, because we understand that you do it all. You're married, you have a family, you have a practice. And I said, and she said, and we don't want to do it that way. Okay. I think what she was saying is you work too hard, you spend too many hours. But in fact, I perceived that I had achieved some kind of balance. So as life changes and we communicate in bits and pieces, and we are constantly even busier than we were the week before, and we change the way we relate to people, then we have to ask ourselves, how do we achieve that balance? Well, one of the culture changes that has happened is we've begun to say, I want much more rigid boundaries between when I'm a doctor and when I'm a mother, golfer, politician, or whatever. In fact, physicians have often become, or have increasingly become, shift workers, creating much brighter lines between their personal and professional lives, replacing in many instances the picture I'm sure those students must have had of me, of a weary physician kind of going from one place to another to I'm a doctor for 8 hours a day and then I go home and my phone doesn't ring and I'm rarely bothered or interrupted. But that also means that we've changed the relationship with our patients because of changing the way that we practice medicine. We are handing our patients off at the end of a shift. Now, we used to laugh about that in the 80s when national health care was being talked about. And we said, so we're going to start working shifts, right? And doctor, even if you're in the middle of a surgery, whoops, my time's up, so put a green towel over it, the next shift will come in and take care of it. We thought we were being funny, but to some degree, we're doing some of that today. We used to believe a lot of people went into emergency medicine because they liked that concept of shift work. But today you can be an OB-GYN, an internist, a family physician, and you can be a shift worker. Handing our patients off much like a factory worker who attaches a particular bolt and then passes the widget down the line, or a cafeteria worker who plops a serving on the plate and pushes the tray down the line, immediately forgetting that tray and turning attention to plopping the next serving on the next tray, impervious to who the tray belongs to or where it's going to go. You know, the first time I heard the concept of laborist, I was appalled, aghast. I'm a family doc by training, but I did a lot of obstetrics over the course of my career. I loved the delivery part. If I done the prenatal care for a woman for 9 months, I wanted to be there for the delivery. And usually she wanted me to be there for the delivery. So when this physician told me that what they wanted to do was be a laborist, I thought, surely there's not really a role for that. But there is. We have intensivists and hospitalists that arose partly as a result of the patient safety move, because the recognition that if I made rounds and then went to the office and something changed with my patient, even though the hospital would call, it wasn't at all uncommon that you were in a room with another patient or you were taking care of another problem. And so the changed patient condition didn't get addressed for 30 minutes or an hour. There was criticism for particularly family physicians, but obstetricians too, that when a woman was going through labor, if you were in the office seeing patients, you might delay a few minutes coming over when you really should have been there hands-on with the patient. So intensivists and hospitalists and now laborists meant there's somebody on deck. They can respond immediately to patient changes. They can respond immediately as lab work comes back. as some decision needs to be made. And it was done in the interest of patient safety. In fact, Leapfrog began to say that if an intensive care unit didn't have an intensivist, they weren't meeting the standard of what needed to happen. Well, it probably does address some of the issues of safety. There's some interesting literature that shows that if you respond immediately, whether it's by protocol or by having somebody there, then you can get people off ventilators quicker. You can get people home a little faster. But there's also a trade-off for that because that means that patients oftentimes kind of feel like they are that widget. They're getting passed from one piece to another. Think about how a patient might feel, for example. Patient calls after hours, gets sent to a triage phone line someplace, and after some discussion is told, well, I think you need to go to the emergency room. The emergency room, they see an emergency specialist who evaluates them and says, I think you need to be admitted to the hospital. Triage, emergency room, and sends them upstairs to the ICU where the intensivist comes and does the evaluation and the workup. And then if she's lucky, the next day when it's time for a rounds, she'll see the same intensivist, but depending on the schedule, she may see yet another doctor. When she's deemed stable and she's moved to the floor, she'll meet a hospitalist, yet another provider that she doesn't know, hasn't got a relationship with, and who doesn't know her. And again, if she's lucky, that same hospitalist may make rounds for 2 or 3 days in a row. But it may also mean that you're hitting the change or the rotational shift and you see a different hospitalist every day that rounds are made. And finally, it's deemed that she's ready to go home, and she goes to the post-acute clinic in order to be sure she gets the right care after discharge, because after all, we don't want any readmissions, and she meets yet another physician. At some point, she may cycle around and see her primary care physician. But in the meantime, she's seen 5, 6, 8 providers, and that doesn't count all the subspecialists who may have been consulted on the case. Well, if these are all really competent people and we're writing magnificent notes in the chart, the care decisions may in fact flow extraordinarily well. But in reality, we're missing some pieces because these are the times in my patients' lives when they're probably their sickest, not when they come to my office for a routine visit of some kind. And these are the times when those discussions that we've hopefully been having over the period of me taking care of that patient, defining what's important to them. What kinds of thoughts have you got about end-of-life care, or who's going to make decisions if you can't make them for yourself? Those are all in my chart someplace. They're all in my memory of that patient. And none of those 4 or 6 or 8 providers know this patient, nor does she know them. So the toughest decisions are being made with a group of providers who, through no fault of their own, don't have those very important conversations. Well, it's a much nicer lifestyle for us. It means that we have severed that relationship between the continuity of care and the difficult conversations that we should be having with our patients and the actual decision making at the time that they're sick. It's had some interesting impact. You know, I rarely board an airplane anymore, that I don't have several members of the airline who are deadheading from wherever they live to whatever airport they're going to initiate their several days of flying. But there's a new group of traveling professionals as well. It's the doctor who decides they want to live on the coast and they're going to go do a few shifts in the Midwest. Or they like to live in New Orleans, but they want to work in Boston. How do I know they're doctors? Well, oftentimes it's just listening to the conversation, but they're almost always in their ubiquitous scrubs, kind of saying, I'm a doctor. And it's fascinating that, in fact, I used to leave town so that I could get away from being on call and having my patients interrupt me. Now you leave town so that you can go and fill a shift to take care of patients. Dr. Lown, there have in fact been many, many changes. More of those changes. About 80% of you, when you finish either this summer or in subsequent summers, will go out and sign a contract to work for a group, a system, a hospital. That's upside down from what it was when you and I finished practice or finished education, Dr. Shack. But it, in fact, says again, I don't want to do the business of medicine. I want to take care of patients. So I'm going to let somebody else do the business of medicine. And it's true. We don't give you good business training in the training that we give you. But while there's nothing inherently wrong with you signing a contract and deciding that you're going to let someone else deal with the business, you've now empowered somebody who has the power of your paycheck to have a great deal of influence over the decisions you make. How many patients do you have to see before they cut your paycheck? How many RVUs do you have to generate? In the worst cases, they may even quietly influence you about where you refer your patients, which consultants or imaging or other pieces you're expected to use. And so it puts somebody in between you and patient decision-making, again, oftentimes with a different expectation. So we seek work-life balance, but it has changed our relationship. We practice in a culture that's changed the way it communicates and how it expects to communicate. Add that to the remarkable technological changes that have happened in the last few decades, and you have a very complex system. We were commenting last night about the rapidity of change in medicine, and you're contributing to that with wonderful research and people who are pushing the boundaries of healthcare. And since I haven't decided what I'm going to die from, I want you to keep doing that, all right? Because I want to be sure that you've got the right treatment for me whenever those days come. But while those things didn't exist when the dean and I were first in practice, most of you would not be comfortable practicing without imaging, modern imaging, lots of the modern pharmaceuticals. In fact, again, we talked about the fact that some of the imaging today is approaching that level of Doc McCoy in the Star Trek, you know. He never had to lay hands on a patient. He just ran that scanner over him, knew exactly what was wrong and what to do. We're getting close. We have medications that are shrinking prostates and improving contractility of failing hearts, curing HIV, not just controlling it. We have the capacity to replace hips and knees and elbows and ankles, transplantation of virtually every solid organ, literally giving people a new lease on life when not too many years ago they could have simply expected that it was time to make their end-of-life plans. High-tech care that requires very sophisticated teams of professionals working with clockwork precision in order to make that work. We love all those new things because it makes us better. We can diagnose better. We can manage chronic disease better. Our patients can and should live longer and better. I don't think at the close of World War II there were too many octogenarians outside playing golf. But today it's not at all unusual. Get on a cruise ship and you may discover there's a whole lot of 80 and even 90-year-olds because we are in fact living better. But in doing so, I fear that we may be leaving behind much of the best of medicine, maybe putting barriers in the way of the very humanism that we are espousing. In this day and time, think about surgery, where the surgeon's actually across the room from the patient, or can be across the state if you have enough fiber and connectivity. Think about the robots making rounds. Literally, okay? I'm doing a lot of work with rural healthcare, and I see videos and pictures all the time of what looks a great deal like R2-D2 rolling up to the bedside and interacting with the patient. That's not exactly the same kind of medicine that many of us train to do. And yet, those robots will bring high-tech care to rural hospitals, without which they might close their doors. That capacity to do Da Vinci surgery means that patients can have really intense surgery done with much less blood loss, fewer complications, and again, can be shared across great distances. But when we do those kinds of things, it seems that we become a little more impersonal, that we are exposed to, and maybe we're actually becoming inured to, the concept that healthcare is no longer that vibrant relationship but in fact, it's relatively impersonal, that it doesn't matter who's providing it. A white coat is a white coat, and that we can hand care off when it's time for our shift to end and time for someone else to provide the care. You're referred to a portal to make your appointment and to get your lab results. You're referred to a physician, but even before you see that specialist, they want imaging and they want lab work done, and your consultation with that physician is a whole lot more about interpreting the tests that have already been done than it is about examining you or talking to you about alternatives in history. Now, I'm not sure that's all bad. A few years ago, I heard a cardiologist futurist. That's kind of an interesting combination, but he stood in front of a group like this and he said, you know, and he held up his iPhone, he said, with this, I can do an echocardiogram and an EKG. I don't need a stethoscope anymore. Well, that's probably true. He said, I can tell better the physiology of my patient with what this iPhone does than I can with my stethoscope. I thought of all those hours of trying to learn what those murmurs meant. And here he wasn't even going to use a stethoscope, he's just going to use his phone. And he's right. It is probably a better ascertainment of the patient's status and physiology. But he's also wrong. Because those crude instruments, the stethoscope, the otoscope, are often the vehicle by which we lay hands on patients. And patients entrust their bodies to us. We probably told you that when you came in for your white coat, that in fact patients with a virtual stranger trust you to examine and know their body. They also, as you lay on hands, it's a time for conversation, for compassionate relational discussion. And that opens up the pathway for patients to entrust us with some of the most important information that might lead to diagnoses and treatment. You don't get that probably, particularly if somebody else is doing the echo and the EKG, and you're just sitting down with the patient and reviewing the results. So while he may have better technology, I would suggest that he's probably missing those entry points to actually have a better relationship with his patients. But technology versus humanity, tech versus touch. You know, all the pressures today are for efficiency. They are for getting the patient diagnosed and treated and moving on. And thoughtful history taking and discussions and listening take much more time. So maybe in this day and time of productivity, of physician shortages, and the fact that there are patients waiting to be seen, maybe all this touchy-feely stuff really doesn't make any difference. We got high tech, we can diagnose you, we can give you a treatment plan, and we'll find some way to begin to talk to you even though we're doing assembly line medicine. Does it make any difference in the long run? Do we really care about whether we have those relationships? Well, turns out it matters a great deal. According to academic medicine, humanism is fundamental to excellent patient care. And they go on to say, therefore, it's important that we teach it in medical schools. It's important for physicians to hone those skills for the whole of their careers. It's important for patients, and it's important for physicians. So let's talk patients first. Patients actually often invite, by the very fact that they come into your office, that physical intimacy. And in return for trusting you, they expect privacy and competence and respect. You know, in the U.S., we've moved from a paternalistic system where a physician might come in and pat the patient on the head and say, don't worry about a thing, we've got this. No diagnosis, didn't tell you what was in the pill bottle, just trust me. We've moved to a shared system, to patient-centered care, maybe even patient-directed care, where that patient can overtly put his or her values and culture into the decisions that are made. But patient-centered care requires that we have those discussions, that we know the patient and their value system and give them an opportunity to say, I don't like that particular potential intervention. And even though you think I should go that direction, I prefer to go the other direction. If without that relationship, then patients really are kind of left floundering, being told they need to make a choice, but they don't have any basis on which to make the choice. A National Academy of Medicine report recently highlighted the potential, both in efficiency and quality, of advanced care planning, shared decision-making, and family involvement. But they said that it's very important that you have that strong patient-physician relationship, communicative relationships. And our fractured system often proves to be a barrier in that happening. So in addition to patient decision-making, your diagnostic tools, therefore the patient's well-being, can be improved with communicative, humanistic relationships. You can go back to Sir William Osler, whom I love to quote, and he said, if you talk to the patient long enough, the patient will tell you what is wrong. The problem is, back to that Snapchat philosophy, we may listen for about 11 seconds before we intervene and ask questions and stop the conversation. And once we've done that, patients often stop sharing. Now they just answer your questions. They don't give you their perceptions about what's going on. I had a colleague on the AMA board. We were talking about domestic violence and some of the issues that are around the healthcare situation, and he said, you know, I just don't get any of those stories. My patients have, maybe we don't have that population in my town. Well, statistically, that's not likely, okay? He and I talked a great deal about it, and he was working on a master's in health administration, and between the two, I said, you know, why don't you try sitting down at the end of your exam time, put a hand on a shoulder or a knee, and really listen when you ask, how are things going? Everything okay? And then be quiet. He came back about 6 months later. He said, it's like a different exam room. My patients are telling me things they've never told me before. Maybe because he stopped long enough for them to trust that he was really going to listen and maybe have something to suggest in those problems. That hand on the shoulder that said, I really am listening. So we are better diagnosticians. And finally, we know that in trusting relationships, patients are more adherent to our treatment plan, and lack of trust is associated with failure to get preventive care, poorer chronic care, and self-management. Failure to build caring relationships with patients may have an impact on care delivery in a multitude of ways, because in some ways we've communicated with our shift work and with our desire to be able to parse out what is personal and what's professional, that a white coat is a white coat is a white coat. It's okay I'm not here. My partner's excellent. It's okay I'm not here. The specialist in hospital care is going to take care of you. And so then, at least as a family physician, I get frustrated when every time I see a patient, they say, well, I've been to the urgent care 6 times. Why come you're not coming here? Oh, it's hard to get an appointment to get in, and it's further to come over here. Urgent care is on the corner. And after all, doctor, a white coat is a white coat is a white coat. But that means the patient is losing the opportunity for those important conversations about what kinds of things are important to them, much more common in the aging population than it is in the healthy middle age. But we never really know when we might become that serious patient, and wish we'd given some thought to those things. Elizabeth Ryder at the Institute for Professionalism and Ethical Practice says that organizational culture not only impacts physicians, but impacts patients and families in their experience of care and their satisfaction with care. The culture of where you practice, not only the culture you bring, but the culture of the practice setting where you are, impacts that doctor-patient relationship. So it matters to patients. It matters to professionals. We should cultivate humanistic characteristics not only for our patients, but for ourselves. Most of you, hopefully, believe in preventive medicine. Most of you probably get a flu shot because you know that reduces the likelihood of you getting the flu or transmitting the flu to your patients. And if you do get it, that it'll be a lighter case of the flu than if you hadn't been immunized, if you hadn't taken preventive measures. Well, doctor-patient relationships is proven to be a preventative for burnout, and burnout is epidemic in the United States in the medical profession today. More than half of U.S. physicians experience professional burnout and depression. Even students and residents are saying that they have burnout and depression. Now, that astonishes me because I think back to how hard most people worked to get into medical school, how much they anticipated what a great step this was going to be. Hard work, no doubt about it. But burnout already before you've even gotten your degree. It says there's something wrong with our system, both of care and of teaching. And one of the preventatives is, and has been demonstrated to be, creating meaningful relationships. Time spent in meaningful interaction with patients, which improves your sense of well-being. We all strive to be thoughtful. In fact, it's one of the things we screen for when we let you into medical school. You know, do you appear to have that caring sensitivity? And then somehow, even though we thread it through the medical school curriculum, by the time we get into practice, it has kind of occupied a back corner someplace while we learn that ever-changing science. Today's delivery system has led to part of the issues for it by constantly demanding that you spend more time in administration, less time in face time with patients, more time generating RVUs, meaning that you spend less time with each patient. And in addition to the regulatory environment, we have a metrics-driven system. So you've got to spend even more time going through those charts and saying, which of the preventive tests haven't I ordered for you? Have you gotten your shots? Have you, rather than saying, Robert, have you thought about, what kinds of activity you're going to pursue to remain physically well as you move into your 60s or your 70s? If you're in your 60s or 70s and have a chronic disease, have you thought about if something awful should happen, what kind of supportive care you want in the hospital? Have you made any arrangements for what kind of living situation should you not be able to go home and be independent? So the culture has changed. It's a practice system that values productivity over humanism. And we all know that we respond to all kinds of incentives, that being one of them. Let me share a little story from the Gold Foundation. They were doing work, as they do all the time with students and residents, but they had a project where they sent students out to talk to patients. Now, they weren't doing the usual stuff. They weren't asking about symptoms or medical history or how they responded to treatment. They were supposed to be talking about who these people were. What's important to you? What do you do when you're not at work? What do you want out of this hospitalization? What would be a successful return to your function? Students who got to know their patients were described as awed by the depth and resiliency of the patients they interviewed. I was momentarily taken aback. Certainly when you get to know some patients, you are impressed with their background or their history or what they've managed to survive. But students were awed. And I wondered how often when we're in the doctor's lounge or we have kind of a bullpen in the clinic where I work, where we gather, I wonder if we aren't exposing students not to things that awe them about our patients' capacities, but rather that diminish patients. Usually we're just trying to get rid of frustration or we're trying to lighten a moment, but I wonder if we don't deride patients at times, and when we do that in front of our students, we're suggesting that we have less respect and appreciation for those patients than is healthy in the exam room. Even though it may de-stress us or deal with our frustrations, it's a long way from the awe expressed by those students with the Gold Foundation. There's one last piece of why professionals should care, and that is professional to professional humanism. We've talked a lot in the last decade about making sure the team appreciates each other, that physicians respect and appreciate what nurses bring, that we all respect what the pharmacy brings, that we no longer have this rigid hierarchy, but we ask each of us to operate at the highest level of our licenses. But during that same period of time, it would appear that our doctor-to-doctor relationships may be being damaged by some of the same things that are damaging our doctor-patient relationships. Gone seem to be the days when I would call the consultant, tell them what I thought was going on with the patient, and expect a call back from that consultant telling me what he or she found. If I'm lucky, I get a letter, sometimes in a timely fashion. But I used to use consultants as part of my CME. So teach me something, so the next time I see this problem, I can be a better professional for the patient. And we don't have that interchange. In fact, a recent study by the American College of Physicians suggested that about 75% of the doctor-doctor descriptions were in fact disrespectful, were not appreciative of what other team members, other physician members brought to the interaction. Whereas we all know that if we can come together and discuss a patient from a primary care perspective, from a surgical perspective, from an endocrinologic perspective, we can probably come up with a better ultimate plan. But we have to be willing to take the time to talk to each other. We not only Snapchat and Instagram and text personally, but we've done whatever the professional equivalent of that is in our interaction with physicians, losing some of the richness that has always been a part of medicine. You know, we've been criticized in medicine for essentially being a guild, that we are self-protective too much. And in reality, what seems to be happening is we are losing some of that togetherness. Well, let's talk a little bit then about what we should do. Because although it seems like a fairly dark picture I've painted, the reality is it's not so much about positive or negative. It's about the fact that culture has changed. And if we're going to hang on to the things that are most important to us in medicine, then we need to figure out how to protect those things in this changed culture, because we're not likely to fix the culture. We may be able to fix our role in that culture. So let's talk a little bit about what we might be able to do in terms of preserving humanism. I believe it is central to good patient care. I believe it is preventative for physician burnout. And in this day and time of shortages of doctors and nurses and pharmacists, we can ill afford to lose any of you prematurely. We need more of you, not less of you. And so if we can prevent you getting burned out, that is good for all of society. I believe that humanism plays a role in patient safety and quality because we're listening to patients and perhaps hearing early warning signs of issues that if we move too rapidly and push simply towards RVUs, we might not catch in the conversation. So it goes without saying that our awardees today provides a beacon of hope for us, and that we should embrace more of those kinds of behaviors. But what do we do in the meantime? Well, I think first we need to acknowledge the role of humanism, and then we need to do something we teach our students, something that wasn't there, I think, when I was in medical school, and that is be self-reflective. Spend a little while in the quiet, if you can find it, and ask, what do you do? How good are you at listening? And by the way, those skills probably work at home as well as they work in the exam room. What behaviors might you be exhibiting that you want to try to work on that would demonstrate to patients that you're there? And then when you consider your responses, think about changes you might make if there need to be any. In addition to reflecting on our own behaviors and responses, we should probably thoughtfully reflect on the culture where we practice. It might be here at Erlanger, it might be at the medical school, but it might also be in a group practice. It might be in a system of care. And if, in fact, you think there are barriers to you practicing humanistic medicine, then you probably have some obligation to your patients, and frankly to everyone served by that system, to see what changes you can make in that culture. They may not have to be big ones, but they can have tremendous impact. Is there a culture that tolerates disrespect, professional to professional, or disrespect of patients? If so, we should speak up and change it. And oh, that takes a lot of courage, because we tend not to like to criticize our peers, our colleagues. And yet we all know that that's one of the tools for getting better. If nobody tells you that you're perhaps not meeting the standard of care, and you don't recognize it yourself, and often we don't, then how are you going to stretch that gap? So if your culture, your practice culture, tolerates disrespect, tolerates lack of compassion and caring, it may fall on your shoulders to try to make some changes. Step back and look at your patient interactions. Do you really listen? Are you glued instead to the keyboard and the screen and muttering non-responsive oral responses when the patient talks? If so, maybe you should be talking about a scribe so that you can have either a person in the room or these days a person across the globe who's transcribing, and you can put all of your attention talking to the patient so that you can, you know what, I see a sign that says use the microphone, and I have this lavalier on, and I bet I didn't turn it on 45 minutes ago. My apologies, because I know there are people listening elsewhere. So if you in fact are not really listening, then maybe a scribe will help you stay glued to the patient rather than to the, we'll try turning that on and hope it doesn't scream. How's that? Okay. To the patient interaction rather than to the screen and typing your interactions. That might even put back some of the stories about patient care that used to be so important in our records and have disappeared in this point-and-click day. Do you demonstrate that you really care about what patients are saying? Do you ask the question of, tell me a little more, explain that a little more? Do you make eye contact with the patient? Just little things that make a huge difference in terms of how the patient perceives that interaction. And perhaps the biggest challenge, and then we'll quit, is how do we do those things in this changing culture? That transient relationship I described, where we have intensivists and emergency room doctors and hospitalists and even laborists, because we're unlikely to do away with those things. They were developed for patient safety, they were developed for life-work balance, but our patients deserve to have relationships. How do we train our students that even though their interface with the patient may be in passing, it may be a day or two, that they have an obligation as culture changes to find a way to put those humanistic characteristics into the interaction with patients. We owe it to the patients to work a bit harder. We've made the changes because it makes our lives better. Now we have to figure out how to insert into that changed culture the things that make their lives better. There are so many things we need to do, so much science we need to learn, so many skills we need to continue to hone, but I don't think any of them is more important than humanism. Let me thank you again for being here to help celebrate what you already do towards humanism and encourage you to help our profession find the answers to how do we put humanism into this new culture of quick conversation, urgency, and transient care so that we can get not only the best of science, but the best of people and caring relationships. And I'll look forward to coming back and maybe at one of these future Alper conversations, you will in fact have given us some solutions. Thank you.
Thank you so much, Dr. Dickey. Dr. Harold Alper began practicing way back in 1947, and he was appointed to the University of Tennessee College of Medicine surgery faculty as a clinical associate professor in 1976. He was a driving force behind the establishment of Chattanooga-Hamilton County Speech and Hearing Center, and he pioneered microscopic and laser surgery in the Chattanooga area. He was a leader in academic and organized medicine, and he was recognized by his patients and colleagues as an extraordinarily competent and compassionate physician. If you count the students and residents that he taught, and there would be no way to do that, and the patients that he treated, Dr. Alper touched thousands of lives. The Alper family established an endowment through the Baroness Foundation to enable the College of Medicine and Erlanger to come together to present an annual lecture on the humanistic, compassionate practice of medicine, and also recognize one outstanding resident physician who is completing his or her training here, who has exemplified the qualities of integrity, respect, and exceptional compassion. We ask each department to nominate a candidate for this wonderful award, and all of the candidates nominated are truly exceptional and show great promise in their future practice. We all owe a debt of gratitude to the family of Dr. Alper, and now it's my pleasure to introduce them to you. First of all, Dr. Chess Alper and his wife, Carol. Ms. Debbie Alper. Mr. Jeffrey Alper and his wife, Donna. And now it's a pleasure to invite Dr. Alper to the podium to comment on his father and the award and participate in our presentation.
Good morning. Welcome to all of you, and thank you so much for attending. I can't believe it's been 12 years since we've started doing this, but it means a lot to our family, and I know it means a lot to the folks here at Erlanger. Dr. Dickey, thank you so much for coming. Your comments reminded me of a lot of conversations I had with my dad over the years. And one of the things he talked about was, he said, I try not to look at my patients as patients. I first think of them as people, because I find that if I think of them in that way, I connect with them quicker, I connect with them better, they connect with me. And he said, regardless of what I have to do to a patient, whether it's surgery, prescribed medication, said the real healing comes in the connection that I make with them and they make with me. He says, take an extra minute, it's all it takes, and they'll know how much you care. So I think talking with nominees last night, they're wonderful people. I assume they're wonderful physicians, but it was more important to hear them tell their stories, what drove them into medicine, and why they're doing what they're doing, what they plan to do. So I applaud them, applaud all of the residents here at Erlanger, the physicians that helped train them. Thank you to Dr. Ford, Dr. Shack. UT College of Medicine has just been so helpful. Julie Taylor in the development office, helping us to fund this kind of program and keep it going. And hopefully we'll be able to do this for many years to come. So thank you again, all of you, for coming.
Thank you, Dr. Alper. I'm going to call out the names of our nominees, and we'd ask you to come down the center aisle, get your certificate from Dr. Alper, and then line up on the front of the room. Each nominee is going to receive a certificate. We want you to put this recognition on your CV. It will help you later on. And the winner will receive a handsome trophy. And we're very pleased this year, for the very first time, that every nominee will receive a cash award. Surprise, surprise.
Don't spend it all in one place.
Okay, first is Dr. Cole Webster from Pediatrics. Dr. Hannah Cox from Pediatrics could not be here, and so I'm going to ask Cole if he will accept her award. Don't spend the money.
I won't. I'll make sure she gets it.
From Internal Medicine, Dr. Byung Ban. From Family Medicine, Dr. Dr. Alexandria Cook. From our urology program, Dr. Nathan Jung. From emergency medicine, Dwayne Jorma. From OBGYN, Alyssa Nagy. And from orthopedic surgery, Dr. Ryan Vasquez. And from our surgery program, Dr. Gavin Wilkes. And it's my pleasure to announce the winner from Family Medicine, Alexandria Cook. So thank you.
I'd just like to thank everyone for this award, the Alper family, to the College of Medicine, Dr. Shack, Dr. Four, Ms. Pamela Scott, and to the Family Medicine Department, Dr. Worthington, Dr. Haynes, and all of our faculty and my co-residents. I share all of this with you all because you guys have made me the physician I am. Thank you.
Let me remind everyone about our reception brunch in the POB dining room immediately following. Please come by and meet Dr. Dickey and get a little bite to eat. Also, I want to have special thanks for Pam Scott, for Bill Reynolds, for Liz Jones. All of them contribute so richly to this entire event. We could not do this without them, and we want to thank every member of the Dean's office. So that's it. Thank you.
Oh, yes. Yeah, should have shown everybody the funny award.
One more.
Appreciate it. Good reminder, especially as we go forward. That's right.
Where'd Bill go?
He's right there. All right. We can do pictures up there too. Very good.